It was a pleasure to be attending the satellite symposium in which we were discussing about the role of monoclonal antibodies for patients with multiple myeloma. So first we did a general introduction about what is the role, what is the mechanism of action of monoclonal antibodies. Is there any rationale to be used in the treatment of patients with myeloma? And the answer in general is yes, because cancer cells in general and myeloma cells in general try to avoid the immune control. So there is a good rationale to use immunotherapy strategies for the treatment of patients with myeloma, and monoclonal antibodies are included within these immunotherapy strategies. We can use monoclonal antibodies as part of the passive immunotherapy when these monoclonal antibodies target antigens present on the surface of the plasma cells and directly act on the tumor. These monoclonal antibodies are called naked monoclonal antibodies, and we can target CD38, but also we can target another different antigens like CD40, CD56, or even molecules present on the bone marrow microenvironment like BAF, APRIL, or interleukin-6. The mechanism of action of these monoclonal antibodies includes some activities like complement-dependent cytotoxicity, antibody-dependent cell phagocytosis, antibody-dependent cell cytotoxicity, and also these monoclonal antibodies are able to induce direct apoptosis of the plasma cells. In addition with this passive immunotherapy, we have also monoclonal antibodies included within what we call active immunotherapy, because these monoclonal antibodies target the immune cells and they try to enhance and to stimulate the cells of the immune system. Within this active immunotherapy, we have basically the checkpoint inhibitors, monoclonal antibodies targeting the PD-1, PD-L1 pathway, often exploited by many solid tumors, but also in myeloma. There is an overexpression of PD-1 and PD-L1 in T lymphocytes and also in the myeloma cells. So there is a good rationale to use all these monoclonal antibodies in myeloma. In fact, if we move to the clinical, so we have already preliminary but also consolidated results about the use of monoclonal antibodies in myeloma. We can use Elotuzumab, a monoclonal antibody targeting SLAM-F7, that it showed no activity as single agent. However, there is a good rationale to be combined with immunomodulatory drugs, and in fact, Elotuzumab was combined with Lendex in a phase 3 randomized trial, the Eloquent trial, and Elo plus RD resulted significantly superior in terms of progression-free survival, and this combination is already approved for the treatment of relapsed and refractory myeloma patients. Another monoclonal antibody is daratumumab, targeting CD38. Daratumumab is already approved as a single agent in the US and also in Europe, according to the results of the Sirius trial, in which daratumumab showed to be effective as single agent in heavily pretreated myeloma patients. And the main benefit these patients get from daratumumab as single agent was a benefit in terms of overall survival, because the overall survival was of 20 months, when for this patient population the median expected overall survival would be only 8 or 9 months. We have also results coming from other CD38 monoclonal antibodies like isatuximab or MOR202, evaluated also as single agent in heavily pretreated myeloma patients with a similar efficacy, approximately 30% of overall response rate, but these new CD38 monoclonal antibodies have not been approved yet. The future, of course, of these CD38 monoclonal antibody effective as single agents is to use them in combination. And in fact, we have already consolidated results coming from daratumumab in combination with two backbone in relapsed and refractory myeloma patients. Daratumumab plus lenalidomide and dexamethasone, evaluated in the Pollux trial with a significant benefit in terms of progression-free survival, complete response rate, and even minimal residual disease negative status. So daratumumab plus lenalidomide and dexamethasone is another new standard of care for the treatment of relapsed and refractory myeloma patients, already approved in the United States, and it will be very soon approved here in Europe because the CHMP gave the positive report just 1 week ago. And not only for Daraa in combination with Lendex, but also for Daraa in combination with bortezomib and dexamethasone, another backbone regime for the treatment of relapsed and refractory myeloma patients. Daraa plus VD was significantly superior to VD, and again it will be a new standard of care for patients with myeloma after at least one prior line of therapy. The other CD38 monoclonal antibodies like isatuximab and MOR202 have been also evaluated in combination with the backbone regimes, mainly IMiDs-based combination, lenalidomide, dexamethasone, pomalidomide, dexamethasone, with encouraging results, but we don't have any result available yet at the present time coming from phase 3 randomized trials. Concerning the other monoclonal antibodies like the checkpoint inhibitors, we have also promising efficacy results when these checkpoint inhibitors have been evaluated in relapsed and refractory myeloma patients, but in combination with immunomodulatory drugs. Because again, one important concept is that these PD-1 or PD-L1 monoclonal antibodies showed no activity or just a very modest activity when they were evaluated as single agent. In combination with IMiDs, the results are encouraging, especially because this combination showed to be active even in patients refractory to lenalidomide or refractory to pomalidomide. But again, we have to wait to have results coming from phase 3 randomized trial. In summary, what is the future of monoclonal antibodies? I think that probably the results coming from CD38 monoclonal antibodies, and specifically daratumumab, because so the development is much more wide than for the other monoclonal antibodies. I think that is to be a backbone to which the backbone regimes are going to be added. And in the future, we will use daratumumab in the upfront setting. And in fact, in the symposium, Dr. Moreau presented the trials that they are being conducted in the upfront setting, combining daratumumab with VTD, one of the standards of care for young newly diagnosed myeloma patients, or in combination with lenalidomide and dexamethasone in the MAIA study for non-transplant eligible myeloma patients, or with bortezomib, melphalan, and prednisone, another standard of care for non-transplant eligible myeloma patients. So at the end, I think that the monoclonal antibodies are going to be the backbone, and of course we have to select what is the optimal sequencing of treatment in the near future for our patients with myeloma. But also, this is an important question, I think, and I would like to summarize the symposium saying that the best, the first. So if we start in the near future to use triplet combinations plus monoclonal antibody, and Dr. San Miguel was talking about the possibility of cure myeloma, I think that with these attractive options of therapy, with this very effective combination coming from monoclonal antibodies plus proteasome inhibitor, IMiD, and corticosteroids, we will be probably able to cure some patients with myeloma.